Thanks, Minister. Today you'll see that we've said there are 10 cases under investigation and 2 that are linked. In fact, I'm aware that 2 of our new cases are additional cases linked to the Box Hill Hospital outbreak, 1 additional case in a patient and 1 in a household contact of a known case. And there is 1 new case linked to the Chadstone Shopping Centre outbreak, which brings that total to 33. I'm also aware of a couple of family outbreaks, so I know people can get concerned about the 10 that are still regarded as under investigation. In a sense they are. We're trying to work out the origin of these family outbreaks, but there is 1 family outbreak in the western suburbs consisting of 5 cases. I don't have further details, and another 1 consisting of 3 individuals across 2 households. So in fact there are 8 of those remaining 10 cases that we have some details on. They are as you would expect, isolating at home, but with further investigations as to the source of those outbreaks. Now, I did say yesterday that we had challenges with respect to time to test and time to isolate. Please don't take that as saying that individuals are doing the wrong thing. I'm not talking about blaming individuals. I'm talking about systemic behavioural challenges for everyone in Victoria. And we all need to support that. It's not just about the individual. There are challenges that are part and parcel of the way our society operates, and the obligations are not just for that individual, they're for everyone who is trying to support those behaviours. So time to testing and time to isolation, I've called out because they are really critical elements and they do make a difference. The robustness of the response to individual cases is only as strong as all of those pieces coming together. If somebody is symptomatic for 3 days before they test, it doesn't matter how quickly that case gets notified, and following them up, there are still 3 days of exposure, potentially to family members, potentially to other people. So I only highlight it because it's a really critical behaviour for all of us to address, for government, for the friends and family of those symptomatic individuals. If you are talking to someone over Zoom or on the phone and they have a new cough, tell them to test. If someone is in your family and you know that they have a sore throat, they've got a new runny nose, they've got a fever, tell them to test. If they are finding excuses not to test, support them to do so. And if they are not isolating, tell them that there are supports available to anyone who tests positive to have accommodation to support them in their isolation. Away from their own family, yes, that's tough, but they'll be supported with a place to stay, food, and as we've indicated previously, a $1,500 payment if there isn't otherwise payments available through their workplace. They're really important elements because this is how the virus transmits, and it takes advantage of the time that others are exposed. The additional challenge is obviously the system response, but we are wrapping every single case with a public health response that is really, in my opinion, robust. We're standing up incident management teams sometimes for a single case, because it has complexities, and we're absolutely standing up an incident management team if the risk assessment for a cluster is that it requires all of those elements, the mobile testing teams, the pop-up clinics, the community engagement that is required to get on top of those, and we do. We've got no new cases in the family outbreaks in Frankston. We've got no new cases in Kilmore. We get on top of these, we're getting on top of them quickly, but there are genuine behavioural challenges that are not about blaming individuals, they're about challenges for all of us, and we have a collective responsibility to play in getting on top of them. Thank you.
So I'll just add to...
I did say yesterday that they were following the outbreak standards that are the national standards. I did check in with them and I provided my view that I think there shouldn't be a 30-minute cut-off for people getting tested in terms of the amount of time spent on the ward. So I think that testing can and should be open to, and I think it is being open to anyone who spent any time on the affected ward. So that does apply to asymptomatic staff, and I think the case for very broad testing again with the end game of coronavirus in Victoria, there's a good reason to test, within our testing capacity, which is very substantial, and we've got room to move in that.
So is that, as of today, staff who spent any time on that ward will be able to get
Well, that's my understanding, yeah.
What is our testing capacity at the moment?
Look, really, we could test 30,000 people in a day if that were required. So I'm not concerned about any of our testing capacity. There are obviously sometimes logistic challenges getting out to a particular location, but even that is working really quickly, as we've seen in Kilmore, as we saw in responses in Colac and elsewhere. So no concerns about testing capacity, and that turnaround time is brilliant. So a lot on the same day. If you test in the morning, you'll get that result in the afternoon, and 96-97% within 24 hours.
With the Kilmore case, we waited, they waited almost a week, or maybe I think it was just a week, for the Victorian government to say, okay, if you've visited Kilmore Cafe, the Oddfellows Cafe, go and get tested regardless of whether you have symptoms or don't. Given our case numbers are so low and we're trying to contain clusters and outbreaks at the moment, and we have testing capacity, would it not be more appropriate to say, right on the very first day, this is an exposure site, you've visited the facility, go get tested regardless of whether you have symptoms or not?
We are moving to that, absolutely. So casual contacts in settings, exposure sites, are being prompted to get tested as casual contacts, not just as close contacts who meet that 15-minute face-to-face or 2 hours in a room definition. So that's a change that's occurred.
When has that occurred?
This week, essentially. Yeah.
With the Box Hill cluster as well, that also took a couple of days for you to come out and say, regardless of how long you've spent in that ward, go get tested, whether it's 3 minutes or 30 minutes.
Yeah.
Are you aggressive enough in, advocating that message or putting out the message for people, go get tested regardless of symptoms or not, if you've been to an exposure site?
I want that threshold to be low. I want us to do really aggressive testing. So I'll be checking in with the outbreak team and landing all of those protocols going forward, but I think that's the view of our case contact and outbreak management team, that we should be as aggressive as we can, again within that testing capacity, and within reason about what the prospects of finding a case are. There's the counter, which is if you test really widely in a population who are at very low risk, then you get false positives, and you end up taking actions that are not necessary and can be very disruptive. But even false negatives are pretty rare in our system. But with tens of thousands of tests being done every day, they do crop up, and they do have consequences as you isolate people or as you shut down businesses or other settings. So we have to have that in mind as well.
And just on that, I know you've sort of moved away from the disproportionate language, but earlier in the week, both you and Dr. Alan Cheng had said testing everyone would be disproportionate. I guess you either test, trace, isolate and have infection prevention control measures in high-risk settings and do that really, really well and err on the side of caution, or you risk a third wave and a lockdown. So the two are just not comparable. So I guess, will it be a feature of the pandemic in your response to positive cases and clusters moving forward?
Yeah,
we on the side of extreme caution when it comes to that.
Indeed, what we regard as proportionate at the end game is different to how it might have been with 700 cases a day. So we have to have a really low threshold for testing. We have to be really aggressive about it. These additional obligations for people to test on day 11 as close contacts might not have been seen as proportionate 2 months ago. I think it is now. And again, we're probably not going to have any additional cases that we find by virtue of that additional obligation, because the great majority of people were testing at day 11 anyway. But you just want every single layer there to capture any potential cases as you possibly can.
There is a primary school in Elwood that there's a message circulating on Facebook that a child has tested positive and that they won't be able to open. Are you aware of that case?
I'm not aware of that. It might be hot off the press from the outbreak team this morning, but I'm not aware of it at the moment.
Given we've been between 10 and 15 cases for more than 3 weeks now, is there a chance we will never get to 5? We will never get to the targets that we'd set to move to the next step, that we might just have to live between 10 and 15 cases a day?
Who knows? No one's been to this point with a second wave anywhere in the world. We are treading new ground. So I won't say in absolute terms what the possibilities are. We can't discount that it might be extraordinarily difficult to drive down to zero, but I think it's possible because I know that with no international travel that doesn't require quarantine in Australia, then you've got a cohort of individuals and chains of transmission that are in Victoria at the moment, where there are tried and true public health measures that can get on top of them. The things that need to be in place are isolating immediately, are quarantining immediately, are testing as soon as you've got symptoms, and then wrapping that public health response around each and every case and each and every cluster. If those things work, we will get there. But who knows in absolute terms if all of those things can fall into place. We're unequivocally focused on that. We're putting every ounce of our energy into it. But as we've always said, this is a collective effort. It requires those individuals to heed that message and to take it absolutely seriously, because the COVID normal summer that we're talking about relies on that. But also everyone around those individuals, everyone in the broader community, to amplify those messages about the things that we must do to get there. Mask wearing, hand hygiene, not going to work when unwell, getting tested straight away, they are all critical things to be in place. And then for government to do the work of that messaging, our behavioural insights unit to understand what the barriers are to people being motivated to do those things, to the best ways to channel those messages so that people understand them and respond to them. All of that needs to fall into place. But can I give an absolute guarantee that that's going to happen? No one could. And no one else in the world has gotten to a point in a second wave where it's been driven down to a dozen cases a day. But if we're the first in the world to get to a point where we can completely snuff out a second wave, then no one will be happier than me.
But at what point do you say, well, we're just not getting there quick enough and all of Melbourne is in lockdown, let's just open up a little bit anyway?
Well, we are opening up a little bit. We will always make those judgments about what opening up we can do with the caseload that we have. But for those who advocate let it run, it's really not that dangerous, let's protect the vulnerable and let everyone else get on with their lives, they don't understand that we've already been to that. That was easing through our first wave, and the aged care sector was overwhelmed with cases, and we had over 600 deaths associated with that. So we have to bear that in mind. We can't go to a place where we've got 1,000 cases a day. And the 725 cases that we peaked at was with a very robust response in terms of the restrictions that were in place. So you can imagine what it might be like if we would have a really free movement of people with that number of cases. So we have to have those balanced decisions all of the time, and we'll review each and every moment. But I think it's absolutely the right focus to have at the moment to get to a point where we've got zero community transmission or such low transmission that it is absolutely sustainable into the long term.
For months now. Oh, sorry.
So I understand the need to extend the state of emergency. What's the rationale behind extending the state of disaster?
Just wanted to ask along the same theme as well. Given we've still had clusters that have grown to considerable sizes, I think it's like 33 in Chadstone at the moment, Box Hill, other family clusters. How comfortable are you with easing some restrictions on Sunday? We also have a number of mystery cases as well, and we haven't been able to reach that threshold.
Yeah, I think the things that we ease we'll do with a degree of comfort. We wouldn't be going there unless there was some confidence that they're the things that can change within the risks that we know are still out there. The mystery cases that continue to pop up, the clusters that can grow very rapidly. We have to have that in mind, and the changes that will be made will have that in mind, absolutely. But it does point to the fact that you really need to understand where transmission is occurring and how, to understand how that risk equation changes with the any easing of restrictions that come into play.
And what does the last night's narrative about our data reveal?
narrative.
The last fortnight, sorry. What's the narrative behind the fortnight?
Look, I think the general trend in aged care in healthcare settings continues to be positive. The number of residents who've become newly infected in aged care has dropped off very substantially. That's a great thing. There are still a number of active outbreaks in aged care, mostly related to staff cases that continue rather than resident cases. So that's a real positive in that space, and I think it relates to the fact that the support to management, the support to outbreak control and all the prevention measures can be much more intense when there's a much smaller number, and everything that's been worked through with the Victorian Aged Care Response Centre to coordinate and collaborate around that. The number of active healthcare workers in acute care, as you know, continues to come down below 20, and that's a positive. What we've seen in the last couple of weeks is that the community cases between workplaces and households has again risen up. Really, we were at just a couple of cases per day outside of the healthcare worker or aged care cases. It's now up to 5 or 6. So we need to get on top of those clusters and those outbreaks. They're the real key things, and that's why I would reinforce again those elements about isolating immediately with symptoms and getting tested straight away.
I wanted to pick up an earlier point that you made regarding the messaging. People getting the messaging and government focusing on that. Public health, as you know, is predicated on 100% of the population not being able to follow rules, either because they're unable to or they're unwilling to. Moving forward, other than, the testing of close contacts on day 11 or just the aggressive casual contact testing, what else would you recommend the government to do in order to be able to contain outbreaks into the future?
I think we're always working on those messages. You'll see some in the weeks ahead, if not days ahead. But it relates to those pillars of response again. So testing we really want to reinforce, and again the vast majority of people doing the right thing, able to do the right thing, wanting to do the right thing. Others have challenges that are systemic challenges in some regards. There are a very small number of individuals who just don't care. We need to reach all of them with all of those elements coming together.
I meant what else are you sort of advising the government or other things that you're working on regarding government policy to be able to contain outbreaks other than the messaging?
Oh, look, I don't think there's anything new in that space. All of the things around the next circle of contacts, the sewage testing and surveillance, other mechanisms of surveillance that we're working on that flag respiratory cases across Victoria that might be an indication of coronavirus, that we can actually check in and see if people have tested. The strengthening of surveillance, the strengthening and coordination of the incident management response and wrapping everything around it, they're in place now. There's not anything new in the public health response in that regard, but it's making sure that they are all those elements, surveillance and response and prevention, are at the top of their game.
So do you think has the government exhausted all of its options on being able to contain outbreaks?
No, I'd never say that. I think we're always in a process of feedback. What are the new challenges? What are the possibilities in terms of responding? Sewage surveillance is a case in point. It's rolled out to new locations, and for regional Victoria it'll be really critical because again it'll get to a point where there are no active cases, and if sewage surveillance pings in a new location, it can be positive after there are active cases for some weeks afterwards, up to 7 weeks, that people can continue to shed the virus and it's detected in sewage. But we will get to a point where all sewage surveillance across regional Victoria is negative on a routine basis. If we see it become positive, there'll be a really rapid and robust response in terms of asking people to come forward for testing, as has happened in Apollo Bay and Anglesea. So that'll be one of those things. So, I would say we are always looking to new ways that we might be able to respond, but at the moment it's really consolidating and strengthening all of those key elements.
On that point, is there still coronavirus in those areas?
Yes, I believe that we're still seeing through sewage surveillance some positive samples that shouldn't concern us. we've had recent active cases there. They'll continue to shed the virus. The sewage surveillance is a very sensitive mechanism, so it does pick it up. But when we know that there's been a period of time and no active cases, we shouldn't expect the sewage surveillance to remain positive.
Can more be done to prevent staff working across, for example, COVID and non-COVID wards, and to make sure we've heard about that a bit in the second wave?
Yeah, the healthcare worker task force, healthcare worker wellbeing task force that has been focused on infection prevention in particular, has really looked at that policy of cohorting staff, and will look to strengthen that in the fullest way possible. That's being rolled out and should be in place across almost all acute healthcare settings. So I think that's a key element that we'll continue to make sure is in place. There are some non-clinical staff that we need to ensure are also cohorted to the fullest extent possible. That's more of a challenge because they, cleaning staff, other support staff can work across wards, but we need to roll them into the testing for surveillance purposes. We need to roll them into the cohorting as well, so that they're not potentially working across areas when infectious.
Do you know when that's likely to happen?
Oh, we're working on it continuously. The cohorting for clinical staff is in place. We are working on the implementation for all staff.
So staff
now.
shouldn't be working across wards now if they're clinical staff?
That's right. Again, to the extent that it's feasible, and it's not necessarily saying one staff member per ward, but it is cohorting to the extent that is feasible, so that there isn't just a free movement across all clinical areas.
Can I ask about fit testing too? Why aren't or I guess when will all of the COVID wards be doing that?
Yeah, again, not really my area. Safer Care Victoria lead this work, and the healthcare worker task force have brought in the respiratory protection program. Fit checking, which is a simpler mechanism just to be assured that the N95 masks sit well on the face and don't feel like they're incorrectly fitting. That's important. That's being done across the board. But fit testing requires some specific skill sets in those who do it, and is a more complicated procedure. I know that they're looking to roll that out extensively, but it's not something that can reach the tens of thousands of clinical staff immediately. But it's probably a question for Professor Andrew Wilson, and maybe we can get some lines from him in response.
We've been in the pandemic for over 6 months now, and healthcare workers have been calling for N95 masks and fit testing right from the very beginning. Why has it taken so long?
Oh, look, again, it's probably one for Prof Wilson to respond to. I think the key elements in protecting healthcare workers are not about a single intervention. They're about a whole bunch of critical elements that need to be brought into the system, including patient flow and the flow of staff, and the ventilation within wards, and the spacing of COVID positive patients. The lessons from aged care about the sudden surge of admissions into hospital was a key issue. They're all elements that need to be addressed. N95 masks have been available, but fit testing is a particular challenge, and I would defer to Prof Wilson to respond to that in full, I think.
How alarmed are you about the Box Hill outbreak?
Oh, we never want to see healthcare workers infected. We know that as long as there are people who are looking after patients who are potentially positive, that there's a risk there. We need to use all of those elements that I just referenced to minimise that risk to the fullest extent possible. And that does include PPE, and it does include fit testing to add that additional level. But all of those things need to be in play. And that doesn't bring the risk down to zero. It brings it down very, very substantially. But those risks will still occur. There are still aerosol generating procedures, aerosol generating behaviours that we're aware of, the shouting and talking that can sometimes bring virus into the atmosphere. So it's not an easy thing to address if you haven't identified a patient potentially. It's much easier when you know that there's a positive case and all of the things that you need to have in place to look after someone. But there'll be some patients who aren't identified immediately as coronavirus patients. There's a really good surveillance process through the emergency department for suspected COVID patients, how they're managed. But it's a continuing challenge.
Should it be sorry?
Well, I'm just wondering, in Box Hill, do you go, hang on, something might have gone wrong here, Are you having a look at it, and have you identified any problems in the system that might have led to this outbreak?
Yeah, again, for Safer Care Victoria, but they do look into each and every one of those incidents, and they looked to a root cause analysis to try and get lessons about what might have occurred. It's not always clear who the index case is. Sometimes they're unidentified. Sometimes there might have been a patient who's come through who hasn't been picked up as the index case, or it might be a visitor. So it's not always easy to have those final determinations, but the root cause analysis process and the investigation of those outbreaks are present routinely.
Should there be a higher assumption in those situations where you suspect that there might be a COVID case? Should you just say, well, it could be a COVID case, so we'll just increase the measures to be sure?
Yeah, that happens. So suspected COVID cases are managed with a particular set of measures to minimise that risk. We do know, though, that there are some individuals who are going to be infectious prior to being symptomatic. They might come into hospital for another reason that has, that might relate to symptoms that are not at all COVID symptoms. So it can be tricky in that sense. You can obviously go to hospital for reasons other than COVID, but you can still be in a infectious phase for it. But suspected COVID patients, I think, are being managed very well through the emergency departments or indeed outpatients or elective admissions.
Can you tell us about aged care?
Sorry, I was going to ask about aged care as well.
Okay, yeah. There's been concerns raised, particularly by Associate Professor Michael Murray, that the system still is not ready if there was to be another outbreak, another wave, that we'd have similar problems again in aged care. How confident are you that enough change has been made in the system, in the processes, so that we wouldn't have this appalling tragedy again?
Look, I think it's a challenge. The Victorian Aged Care Response Centre has done a power of work. They've been very collaborative. They've had so much investment in the not just the response and the coordination of that response, but in looking at the prevention measures in aged care as much as possible. But it's my personal view that there are systemic, intrinsic vulnerabilities that are still present in aged care. There's a Royal Commission into it for a reason. There are a number of challenges, and I think they're not easily solved overnight. And I think we will need to continue to work through the VACRC, but with everyone in the aged care sector to reduce those vulnerabilities as much as possible.
Do you think it's ready?
I think we need to continue to work on it. I don't think we should sit back on our hands with aged care. The vulnerability there has played out with the deaths that we've seen, and we have to work continuously to make sure that that risk is mitigated to the fullest extent.
Just back to, and on October 2nd, you went into a little bit about the genomics within the hot hotels. Since then, have the investigations found anything, and also have we ruled out any contract tracing links between the hotels and external cases?
Not that I've seen. No, nothing new on that front.
But the investigations are done and finished, or not?
With respect to what?
All the cases from the hotel, positive cases for people working in hotel quarantine. All the contract
that
cases.
we recently spoke to.
Yeah.
Yeah, as far as I know.
Just on contact tracing again, my understanding is that early in the pandemic, aged care staff in facilities were relied on quite heavily in order to be used to contact close contacts. Was that the case, and how long did that occur for?
Look, it's still the case in as much as we need to have the details that only an aged care facility will have about who was on a shift on a particular day. So that's kind of true for any business. It's true for any setting that you need to know who was there and you need to know when they were there. So we rely on that, but we have outbreak squads that now go out on site immediately, and if they are useful in helping steward through that process to make sure that that's clarified immediately, then they're doing that.
How long were they you said that there's squads that go out, but how long were they relied on in order to do essentially the contact tracing?
They weren't doing the contact tracing, they were providing the information that our contact tracers were using to follow up with those everyone who's considered a close contact in aged care. But I'm not sure the exact date that the outbreak squads were in place.
On those 2 new family outbreaks, you mentioned there's one in the western suburbs.
They're both in the western suburbs,
They're
as I
both-
know. Yeah.
Do you know which suburbs?
No, I'm not. I'm not absolutely sure on that. We can come back to you.
With the Chadstone cluster, have any asymptomatic people tested positive to COVID?
I don't know. I haven't heard that. It's not beyond possibility, and maybe it can be part of the show update in the afternoon.
Actually, mystery cases, how are we doing?
Mystery cases. So I know we're down to 10 at the moment, but there are some additional mystery cases that I have some details on. At least I hope so. Or I will have that in the update this afternoon. Oh no, two new mystery cases with postcodes that are now defined. So 3147, which is Ashburton and Ashwood. Again, that's a call out to people to come forward for testing immediately if they're symptomatic. That applies everywhere, but Ashburton and Ashwood to be a particular note. And 3037, that covers Sydenham, Taylor's Hill, Hillside, Delayey and Calder Park.
And can we have just one more question on the phone records, just so we...
It's a good night in mine.
This is why no one likes cats.
That's not very fair, lady. It was a big week. They probably played the final last week. It was pretty good game of footy last week. Anyway, all the best.
Cheers, guys.